The purpose of this lecture is to talk about endocrine disorders. Now we know that we have several objectives for the endocrine disorders content. In this first recording, we're actually going to talk about the pathophysiology and the manifestations of thyroid and adrenal cortex endocrine disorders. But before we launch into specific pathologies, I think it's helpful to look at an organizing framework that can be very helpful when you think about endocrine and you address endocrine disorders. So you have to think about where the hormone is produced. What's the physiologic purpose of the hormone? What stimulates the release as well as decreases the release of the hormone. Remember that the endocrine system is all about communication. With hormones, we're thinking about the communication between the tissues. That's what endocrine means, communication between the tissues. Within that communication system, we think about a series of feedback loops. What turns the hormone on and what turns the hormone off. And that's where the feedback loop comes in. So you have something that stimulates the release of the hormone. The hormone does its work. Once it does its work, then that feedback loop has to decrease then the release of the hormone or turn it off. When you take that the next step, when the hormone is not present, what's the pathology? How do you know it's not present? What's the effect of the pathology? When the hormone is present in larger amounts than needed physiologically, again, what's the pathology? How do you know there's too much? What's the effect of having too much, or what's the effect of the pathology? The other thing to remember with the endocrine system, remember it's communication between the tissues, is that pathology can occur anywhere in the system of communication. So it could be occurring at the releasing hormone or the releasing factor level. Hormones are released due to chemical, endocrine, as well as neural factors. Or the pathology could be with the hormone itself, or it could be at the target organ level. Target organs have specific receptors for each hormone. Cells then adjust their sensitivity to those hormone signals. Remember when we talked about first and second messengers? Well, first and second messengers are key to the understanding and are very key to the pathology in the endocrine system because there is so much communication. So we know that hormones are first messengers. These first messengers, the hormones, activate or bind to receptors. When that happens, enzymes produce the second messenger. Those second messengers then activate intracellular enzymes that allow the response to the hormone itself. Let's take a closer look then at target cell responses. When you think about a target cell response, or where the hormone is actually going to do its work, you have to think about, could this be a receptor issue, or is it intracellular that is the problem? So let's look first at receptors. We know that target cells have the ability to both decrease as well as increase the number of receptors, decrease the number of receptors, or increase the number or the sensitivity of the receptors. Low levels of hormone actually increases the number of receptors. We call this upregulating the receptors. High levels of hormone decreases the number of receptors. This is called downregulation of the receptors. And remember, the hormone is the first messenger that binds to the receptor. So those receptors could become very insensitive. Maybe they didn't change their number, but they aren't as sensitive as they need to be. Maybe in many of the pathologies we'll talk about antibodies, and antibodies being developed against the receptors. Or the receptors themselves could be damaged or unusual or responding unusually. Is it an intracellular issue? Perhaps the post-receptor signals have become defective. Or that second messenger, doesn't get synthesized, or the response is inappropriate. The second messenger, remember, has to activate the intracellular enzyme that then yields the response to the hormone. So let's take a look at that. So let's look at a second messenger, cyclic AMP and glycogen. So you start off with the hormone, the first messenger, insulin. That hormone then stimulates intracellular ATP. That then leads to cyclic AMP, which is adenosine monophosphate, the second messenger. That cyclic AMP, our second messenger, activates protein kinase, which then goes to the liver. In the liver then, we convert glucose to glycogen because of the activation of liver enzymes. So with that conversion of glucose to glycogen, that's how we get storage of our glucose. So that's just an example of how we use that intracellular, that second messenger system. So with that background, that brief introduction, let's start with pathologies. And the two pathologies we'll address at this point are thyroid hormone and adrenal cortical hormone. So let's start with thyroid. Whenever you have in the endocrine system, you virtually always have either too little or too much, and you'll find that they balance each other out. So my recommendation is that as you're studying this, you put them side by side and see how they differ and how they and so that you know the difference between hypo and hyper. When we think about the manifestations, even both the lab manifestations as well as the physical manifestations, they tend to be in direct opposition of each other. So if you learn one, you've kind of got the other. So let's think about the basics of thyroid hormone, because it is such a great example of all the steps of how hormones work. When we think about thyroid hormone then, it all starts in the hypothalamus. The hypothalamus releases thyrotropin-releasing hormone, or TRH. That then goes to the anterior pituitary. So from hypothalamus with the releasing hormone goes to the anterior pituitary, which releases the stimulating hormone, thyroid stimulating hormone, TSH. The thyroid stimulating hormone then actually goes to the thyroid gland, which then releases thyroid hormone. So you can see it's a series of steps. All of this communication from a releasing hormone to a stimulating hormone and now to the hormone itself. And this is one of the more stepped out hormones that we'll study. Now, when you get to the thyroid gland, there are two forms of the hormone. There's T4, which is thyroxine, and T3, which is triiodothyronine. 90% of the hormone is T4, or thyroxine. T4 converts to T3, triiodothyronine, in the tissue. And this is the more active form of the thyroid hormone. So T4 gives up an iodine molecule and converts to T3, the more active form in the tissue. So we know then that when we look at as we look at hypothyroidism, frequently this is a primary disease of the thyroid gland. Now it could be in the anterior pituitary, but usually with hypothyroidism, we're looking at the thyroid gland itself. We also know that iodine is needed for the synthesis of thyroid hormone. When we look at the symptoms of hypothyroidism, these symptoms are going to be related to decreased metabolism, because thyroid hormone is important for protein, carbohydrate, and fat metabolism, our food sources. So when we think about symptoms that would be related to decreased metabolism, when there is less thyroid hormone than necessary, you're going to see less heat production and less oxygen consumption. So when we think about the primary then, think about how this would manifest on your lab results, but also think about the physiology behind this. If this is a primary disease of the thyroid gland, which tells you the thyroid gland isn't responding, you would have low levels of that T3, thyroid hormone 3, triiodothyronine, as well as especially low levels of T4, the thyroxine. However, you would have high levels of the stimulating hormone and the releasing hormone. And this is an important thing to remember with hypothyroidism. You're getting the message, so the releasing hormone and the stimulating hormone is high, but when they get down to the gland itself, the gland is not responding to the stimulation. Therefore, you see low levels of both T3 and T4. And this may result in something called myxedema coma. This is a very, very hypometabolic state and can be a medical emergency. The most common form of hypothyroidism is Hashimoto thyroiditis. This is due to an autoimmune destruction by lymphocytes and circulating autoantibodies. The autoantibody in Hashimoto's is thyroid peroxidase antibody, and this is present in about 90% of patients. Now, although the majority of patients with Hashimoto's thyroiditis are hypothyroid, not all patients are hypothyroid, but generally you're going to think hypothyroidism. In addition, this frequently has a genetic predisposition. You'll see Hashimoto's run in families. But remember, this is an autoimmune destruction by both the lymphocytes as well as circulating autoantibody, the thyroid peroxidase antibody in the majority of patients. So while this is the most common form of hypothyroidism we will see, there are other forms that we need to be aware of as we look at pathophysiology. In postpartum thyroiditis, this is something that tends to occur in 6 to 12 months, tends to occur 6 to 12 months following the birth of a child. This results in a painless enlargement of the gland and is frequently actually associated with Hashimoto's thyroiditis. Although the woman may be hypo or hyperthyroid, they usually are hypo, and they again develop an anti-thyroid antibody. In congenital hypothyroidism, this is when the baby is born hypothyroid. The thyroid hormone is essential for embryonic brain development. So if mom is hypothyroid and has not been able to transmit that hormone through the placenta, the baby is born with a congenital hypothyroidism. It's very important that we screen for this at birth, and this is one of the many things we screen in Texas as part of the newborn screen. And we have to screen for this at birth because the symptoms of congenital hypothyroidism are usually not evident until about 4 months of age. Certainly, if we remove or we ablate the thyroid gland, the individual would be left with hypothyroidism. And that's what frequently happens in the treatment of hyperthyroidism. While we may have tried to ablate part of the gland, we might have ablated the entire gland. If we ablate the entire gland or remove the entire thyroid gland, the individual is hypothyroid. There is no secondary thyroid gland. And then last but not least, carcinoma. With carcinoma, the biggest risk of thyroid cancer is in someone who had ionizing radiation as a child. Frequently with thyroid cancer, though, they may either be euthyroid, which means their thyroid levels are okay, or they may be hypothyroid, and frequently they would have a nodule found on the thyroid gland. So if we go back to this hypothyroidism and identify how this might manifest, again, let's think about decreased metabolism, decreased heat production, decreased oxygen consumption. So as a result then, you would watch for the manifestations of decreased heat production and oxygen consumption. The individual has a cold intolerance. They frequently present with hypotension and bradycardia. They may be presenting with depression, with poor memory, with elevated lipid levels, more likely in an adult on that one. Now, if we talked earlier about congenital hypothyroidism, so if we measure their level of thyroid gland, which is what we would do, we would find a very low level of that. Another population that we want to be very careful with or very alert for hypothyroidism are teens. Teenagers tend to be more susceptible to environmental chemicals that can challenge the metabolism or the uptake of iodine, and as a result become hypothyroid. The hormones are the chemicals that are more likely are the nitrates, the perchlorate, because they block the hormone synthesis. Let's look at the other side of the thyroid gland, or thyroidism, and look at hyperthyroidism. Went too fast. So with hyperthyroidism, now remember, T4 competes to T3 in the tissues, and T3 is the most active. Now, many people call hyperthyroidism thyroid toxicosis. We really shouldn't use those terms interchangeably. So what we're going to talk about is hyperthyroidism. This is a general descriptive term and usually, once again, relates to primary disease of the thyroid gland. Now, as we talked about, now we can look at the flip side then of hypothyroidism. So the symptoms are going to be related to increased metabolism, and you're more likely to see an enlarged gland. So with that increased metabolism, there would be more heat production, more oxygen consumption. As a result, then, manifestations that you would expect might be hypertension, cardiac palpitations, tachycardia, atrial arrhythmias, especially atrial fib. They would have, what would their temperature intolerance be? Yes, they would not be tolerant to heat because they're hot all the time. And unexplained weight loss. They're losing weight and they haven't been trying. When we think about a primary hyperthyroidism, as you can see on the slide, the labs are in the opposite direction of hypothyroidism. So with hyperthyroidism, you would see an elevated level of thyroid hormone 3 or T3, an elevated T4, and a decrease in the thyroid stimulating hormone. And this can result in a thyrotoxic crisis. In myxedema coma, everything slowed down a lot. In thyrotoxic crisis, everything is really speeded up, and so you have someone who is very hot, whose heart is just racing to beat the band. Everything is fast as the blazes. Now, there are two primary kinds of disease we'll talk about. We'll talk about Graves' disease, and we'll talk about nodular disease. Graves' disease is an autoimmune disorder. And this is thought to be a combination of both genetics as well as environment. So once again, you'll see this in families. Those of you that remember the first Bush presidency, both President Bush and Mrs. Bush in the first Bush presidency had Graves' disease. The antibody that we're looking for here, what happens is the autoantibodies bind to the receptors in the thyroid gland itself. And those antibodies that bind to those receptors act just like thyroid stimulating hormone. And this is the thyrotropin receptor antibody. We know that in Graves' disease, our regulatory mechanisms become ineffective. Because of the autoimmune disease, our ability to turn off that gland become ineffective. With Graves' disease, you'll also frequently see something called exophthalmos, which is a lot of periorbital edema, and the eyes actually protrude somewhat, as well as pretibial myxedema. Nodular disease is another etiology for hyperthyroidism. One of the big things we want to remember about nodular disease is we don't really know, or frequently we don't know, the specific cause of the nodules. However, We do know that there is a potential for malignancy, and these nodules are palpable. Now, the nodule itself may cause either an elevated or a decreased production of thyroid gland, though frequently it is increased, and the nodule may either be malignant or benign. What's different about this is, please note that the exophthalmos and the myxedema that was present in Graves' disease is absent in a nodular pathology for hyperthyroidism. Now, once again, let's look at some differences in hyperthyroidism. Younger individuals, especially teenagers or children, tend to present more with the sympathetic nervous system activation symptoms of hyperthyroidism. So they are more likely to present with anxiety, hyperactivity, or a tremor. Elders are much more likely to present with the cardiovascular symptoms, shortness of breath, atrial fib, and weight loss. So different age groups will present their hyperthyroidism a bit differently. So we want to remember that when we think of our manifestations. Now let's turn our attention to the adrenal cortex. Once again, this is one of the glands or the hormones that has a series of steps. So with the adrenal cortex hormone, we start once again in the hypothalamus. And we start with corticotropin releasing hormone, or CRH. From the hypothalamus, the corticotropin releasing hormone goes to the anterior pituitary. In the anterior pituitary, ACTH, or adrenocorticotropic hormone, is released. That tropic hormone then goes to the adrenal gland. The adrenal cortex produces mineralocorticoids and glucocorticoids. Remember, we're talking about the adrenal cortex, not the medulla. Epi comes from the medulla. We're talking about the cortex. When we think about the mineralocorticoids, we are especially concerned with our stress response. When we think about the glucocorticoids, we are especially interested in our steroid hormones and how and their activity on carbohydrate metabolism, as well as the important role of glucocorticoids in our immune inflammatory response. Let's start by looking at hyperfunction. So let's start with the glucocorticoid side, or the glucocorticoid production, and that is Cushing disorder. In hyperfunction of the adrenocorticoid hormones on the glucocorticoid side, we have an increase in cortisol because that's the glucocorticoid. This could either be at the level of the gland itself, or it could be due to a pituitary adenoma, which increases the ACTH, and if you increase ACTH, it goes down to the gland, and then you would still produce more glucocorticoid. If it's a pituitary tumor, then you would see an increase in ACTH. If it's an adrenal tumor that's causing too much glucocorticoid, you would see an increase in the amount of cortisol. What happens with hyperfunction in Cushing disorder is you have a loss of circadian secretion patterns of both ACTH and cortisol. At the same time, because of the hyperfunction, the gland is unable to continue to increase ACTH and cortisol in response to stress. With hyperfunction of the cortisol, the glucocorticoid, in Cushing disorder, you generally see an accumulation of adipose tissue, insulin resistance, and protein wasting. And you've probably seen this in individuals who take prednisone, which is a glucocorticoid, on a regular basis. One of the most problematic things with Cushing disorder is glucose intolerance. And it's because of the increase in cortisol. Cortisol increases insulin resistance, glucogenesis, and glycogen storage. So as a result, then, you have concerns about hyperglycemia. They don't have type 1 or type 2 diabetes because it's a problem with their cortisol. The second thing to think about in the adrenal cortex hormones is the mineralocorticoids, and that is aldosterone. In hyperfunction, if it's a primary or if it's an adenoma from the adrenal cortex, you'll see excessive secretion of mineralocorticoid, excessive secretion of aldosterone. If it's a secondary dysfunction, this is frequently due to the renin, angiotensin aldosterone mechanism, often from a renin-secreting tumor. So what happens then if we have a decrease in the adrenal cortical hormones? What happens in hypofunction? Well, this is called Addison's disease. In Addison's disease, there is a decrease in the cortisol and aldosterone synthesis. So because you have less cortisol and less aldosterone being synthesized by the adrenal cortex, you'll also see an increase in the ACTH. Remember, ACTH is, the purpose is to make you increase your cortisol and aldosterone synthesis. So if the gland isn't working, ACTH is just going to flog it because they want the hormone. Our concerns then would be with this loss of the adrenal cortex hormones would be in terms of our stress response and issues then with our fluid and electrolyte balances. Generally, with hypofunction, with Addison's disease, once again, this is primarily due to an autoimmune destruction of the cortex. As a result of the autoimmune destruction, autoantibodies and autoreactive T cells begin to break down the adrenal cortex. And we also see a deficiency of immune suppressor cells. Remember, immune suppressor cells are part of our immune system, and they're supposed to actually turn off our immune system at some point. However, because there's a deficiency of those suppressor cells, you continue to have the immune system active. In a secondary hypocortisolism, this can be due to prolonged suppression of cortical secretion. And this is what you'll see in someone who has been on glucocorticoid, prednisone, for a very long time. That's why you have to taper someone off so that their adrenal cortex can remember that they have to start producing those hormones again. So being able to balance those out, too much adrenal cortex hormones, too little adrenal cortex hormone. So what do I expect from this section? Do you understand that whole idea of the feedback system and the feedback loop? Once the hormone does its job, the effect should turn the hormone off. And it should turn it off when we talked about the adrenal cortex and thyroid, it should turn it off at the hypothalamus level. We talked about the important roles of first messengers and second messengers in the endocrine system, and the idea of the receptors and what happens to upregulate as well as downregulate the receptors. It's important that with thyroid and with adrenal cortex, you be able to differentiate among both the hypo and the hyper effects of both of those hormones. And then remember, we talked about the role of the immune system in both of those pathologies. If you have any questions, please let me know. Thank you for your attention.